Discussing about asthma and COPD. So we see a lot of cases in our day-to-day basis. Patient coming with asthma and COPD. How do you differentiate them? So how do you treat them? That is the discussion today. So first we go into the case-based scenarios. We'll discuss what is asthma and what is COPD. So generally, asthma is a reversible airway disease. So asthma patients are generally young. They have some kind of atopy or allergy history or food allergies will be there, and they'll tell more of a diurnal variation. So they have more nocturnal symptoms. They'll tell more of the wheezing or shortness of breath in the night, and also seasonal variations will be there. Like they'll tell it is more in the rainy season or autumn season or winter season, on exposure to cold air or some kind of pollen. So some triggers will be there. After doing some exercise, they'll have some asthma attack. So some trigger will be there. Mostly young will be there. Variation, fluctuation will be there. So that is the classical history of asthma. Whereas COPD is mostly seen in the case of elderly people because most of them have some history of smoking or some biofuel exposure will be there, and they have more no fluctuation will be there. They have more of a progressive shortness of breath, fatigability will be there. The fatigability shortness which is more progressive in course. So and they'll have symptoms like cough with sputum, and generally asthma will also have cough that is more of dry cough, but COPD patient will have more of cough with sputum because of chronic bronchitis and all. And they have sometimes they'll also tell about the hospital admissions previously because of some infections, and they'll have X-ray suggestive of some hyperinflated lungs or hyperlucent lungs will be there in COPD. So these are the main features that is helpful in differentiating asthma and COPD. Now we'll go into the case-based scenarios, and we'll discuss further. So a 24-year-old female present with the complaints to OPD with the complaints of nocturnal cough increased on exposure to cold air. So first thing is this is a 24-year-old female. Generally, COPD is unlikely to come in younger people because COPD is generally elderly people, because most of the causes of COPD are smoking or some biofuel exposure or environmental causes. Sometimes genetic causes can cause COPD, like especially alpha-1 antitrypsin deficiency that can cause emphysema disease and COPD, but it's unlikely to cause a diagnosis of COPD in younger age. And most of the asthma also occur in younger people. Elderly people, to label an asthma and elderly is unlikely. Most of the asthma starts in the younger age groups, in the childhood or adolescent group. So this is a 24-year-old that is more in the favor of asthma. And one thing, she's complaining of nocturnal cough. So she's telling classically a diurnal variation is there, and also increase in exposure to cold. She's also telling a particular trigger. So there is no progressive shortness of breath. Any cough with sputum is not there, and also she doesn't have any smoking history. Any hospital admission is there. So this might be a case of in favoring in the case of asthma. So how do you treat this case? So first thing, in asthma management, mostly we use inhalational corticosteroids. Then we go for LABA. Then we go for leukotriene antagonists. There are biologicals also, but first thing is always LABA. You can also use anti-muscarinic antagonists. First line of management is always long low dose inhalation corticosteroids plus formoterol. That is LABA. So here you asked about the symptomatology, how frequent she is getting nocturnal cough. So based on the symptomatology, you can decide whether you should put them on need, like only when needed, when the symptoms are there you can use treatment, or put them on maintenance therapy. Let's say this patient is having symptomatology every once in a week, then you need to put them on inhalational corticosteroids and low dose inhalational corticosteroid plus LABA on a maintenance therapy. Let's say she's having infrequent symptoms, that is once in a month or twice in a month, that is infrequent symptoms. Then you can ask them to use the inhaler of low dose inhalation corticosteroid plus LABA only when needed. So any patient complaining of symptoms at least once a week, you need to put them on maintenance therapy. So if this patient, since cold air exposure is there, maybe during the winter season, if she's complaining frequently and at least once a week, then you need to put them on maintenance, at least especially during the winter season. A low dose inhalation corticosteroids LABA, that is you can use 4 accord 100 or 200 twice a day. That is 100 and 200. What is low dose? I'll mention it in the later slide. Anything 4 accord 100 or 200 is considered as low dose, that is 100 micrograms of butanoside or 200 micrograms of butanoside, that is considered as low dose. So that can be used at least twice a day. So that might be the treatment in this condition. So a 65-year-old smoker now present with the complaints of shortness of breath, which has been increasing since last few months, associated with fatigue, has no cough or sputum. So here is more elderly, so that is more suggestive of COPD. One more thing, complaints of shortness of breath. So which is progressive. There is no diurnal variation. There is nothing like any trigger is there or any change in the seasonality is there. No atopic history, allergy history is there, and smoking history is there. So that is also in favor of COPD. And the next thing is any associated with fatigability and progressive shortness. He doesn't have cough or sputum. So generally COPD has three things. One is chronic bronchitis. Next is emphysema. Next is small airway disease. Emphysema is more of hyperinflated lung, hyperlucent lung. They don't have much of symptomatology like cough or sputum won't be there. So more of the air trapping will be there in them. So that is emphysema. Whereas chronic bronchitis in the other case has more of symptomatology. They have more chronic cough or sputum. Chronic bronchitis is classically defined as any cough with sputum production for more than 3 months for 2 consecutive years is defined as chronic bronchitis. So they have more symptoms. So this might be a not be a case of chronic bronchitis, but there might be a case of emphysema that might cause COPD. So this might be a variant of emphysema as variant of COPD. So based on the history, we diagnosed as emphysematous related COPD. So how do we go about this patient? How do you treat? So generally in COPD, we don't advise inhalation corticosteroids. We generally start with LABA or LAMA, and then we plan on adding both. So steroids are only indicated in few cases. We will discuss what cases they're indicated in the later system. But we need an add a LABA or LAMA. What we add? We added both or we added a single drug. So we based on the symptomatology we need it. If the shortness of breath is significant or the symptoms are significant, based on their scoring systems like MMRC and CAT scoring was there. Based on that, we need to decide whether we add a single drug or we add a true drug. So there is a scoring system, there is a classification also. Based on that, we need to add. Here, if the shortness of breath is not very significant or no symptomatology significant, we can start on single LABA or LAMA. Or if the symptoms of shortness of breath are significant and symptomatology is there, then you can add both LABA plus LAMA. So what is LABA? We discussed formoterol is the most common thing. Is we can use salmeterol also, but formoterol is the most common thing that we use. Formoterol twice a day is what we use. And next we add LAMA. LAMA we have tiotropium, and also we have glycopyridine is available. So and there are also combination of both. Like there are combination drugs also. So one thing, the three options for us, we can use tiotropium alone, like the Tiova inhaler is available 9 micrograms that can be used once in a day. So we want to combine with formoterol, we can advise a formoterol inhaler that is used twice a day. So that is one possibility, Tiova once a day and formoterol twice a day if you want to use a combination. Otherwise there are inhalers like Foroglin plus, where formoterol plus glycopyridine is there. So both act for Forocort and glycopyridine act for 12 hours. So you can use twice a day. So that is 12-hour action, you can use twice a day. Combination inhaler is that is Foroglin plus. And there is one more inhaler called Diova that contains both tiotropium plus Forocort, that can also be used once in a day. If needed, we can make it twice a day. Initially start with once a day. If needed, you can make it twice a day. That is a combination of Forocort plus tiotropium. Forocort acts 12 to 24 hours, whereas tiotropium acts for 24 hours. So that is why you can use the combination of both. If you want to use alone, you can start with at least Tiova once a day or Forocort twice a day. Like based on your call. If the patient has frequent admissions or frequent hospital infections or like frequent exacerbations are there, I prefer LAMA or LABA. So you can start Tiova once a day. A 50-year-old female who is from village now present with complaints of chronic cough with sputum production. So a 50-year-old female who is actually from a village and is now present with complaints of chronic cough with sputum production. So there is cough with sputum production that is there. So that is one more. The asthma is also sometimes will have cough with sputum production, but the variation, the diurnal variation is there, is not, that is all seasonality, any allergy history you need to ask. And then she's from a village. So all the people who are from a village, especially older people, they have some exposure to the biofuels. So they are all at risk of COPD. You need to ask that. So any biofuel exposure is there, you need to ask them all. And then cough with sputum. This is more in suggestive of COPD. So in COPD, how do you manage the patient? So again, in the same way, based on the MMRC and CAT scoring, you grade the COPD. So then you decide them. So all the patients are COPD and asthma, you need to get a spirometry done. So then you can properly tell whether the reversibility is there or not. Based on that only you can tell. These are all clinical features. What I am telling is more suggestive of COPD or asthma. For definitively telling whether it is a COPD or asthma, there are various things you can. In asthma, you can do allergen challenge test, and also you can do FeNO fractional excretion nitric oxide test. FeNO we can do, and also we can do the spirometry on the post bronchodilator reversibility is there. So based on the reversibility only we can tell whether it is COPD or asthma. So all the patients before starting on some drug, it is better to get a spirometry done. So always send them for spirometry. So this clinically it is suggestive of more of COPD, but definitely to tell it is COPD or asthma, you need to put a spirometry done. So this might be COPD or asthma. You need to start them or LABA or LAMA. So a 14-year-old boy with a history of atopian allergy now presented with complaints of wheezing, especially in the case of rainy seasons, and is waking up middle of the night once a week. So classically they told the history of asthma that is there clearly. So he's telling once a week. So So any patient who is having symptomatology at least once a week or twice a week, you need to put them on maintenance therapy. If he is having once in a month or like that, you need to put them on only on treatment, on like when needed only he can take the low dose inhalation corticosteroid plus LABA. So you need to start them on low dose inhalation corticosteroid plus LABA initially. If he's still having symptom, you can make it medium dose inhalation corticosteroid, that is around 400 Foracort 400, that has 400 mcg of budesonide is there. So you can tighten it. 100 to 200 is low dose. Anything more than 200 is considered as medium dose. So you need to initially start them on low dose for Foracort, that is Foracort 100 or 200 twice a day. Then go based on the symptomatology. A 50-year-old male known case of COPD has history of shortness of breath while walking on the level ground and has symptoms of cough with sputum. What is the treatment of choice? So it is a 50-year-old male. COPD is already diagnosed with COPD, has shortness of breath while walking on level ground. So while walking on level ground, he is having shortness of breath. That means he is at least having MMRC of 2. So what is MMRC grading? I'll tell you. 0 is strenuous exercise. 1 is slightly walking uphill. 2 is walking slower than his peers group. 3 is he has to stop after 100 meters. 4 is too distinct to walk. So this comes around 2 at least, and is also having significant cough with sputum. So this having patient has both shortness of breath is also on the higher side, and cough with sputum is also there. Significant symptomatology is there. Maybe this patient will into the B category where you need to combine both LABA and LAMA. So as we told, we can use Tioga once a day and formoterol twice a day, or you can use DOA inhaler once a day. That combination of formoterol plus tiotropium, or you can use Foroglin plus, where is a combination of Foracort plus glycopyridine twice a day also. So these are all the possible combinations you can use. So this is that LABA plus LAMA is an option in this case. So a 20-year-old male who is preparing for his police training, he is complaining of wheezing and cough after running especially. So there is something called exercise induced asthma. So after exercise, because of the dehydration and all, there is a bronchoconstriction. So this might be treated. That is also, any asthma patient is based on the how frequency the symptoms are there. If the patient is polystraining, he might have daily symptoms. In them, you need to put them on maintenance dose of low dose inhalation corticosteroid plus formoterol. But let's say if the patient is running only once in a month or something, only then he is having symptoms, you do not put them on maintenance dose. Only when needed, only less, just is exercising today, ask them to take low dose inhalation corticosteroids LABA on that day, just before going for exercise. 10 to 15 minutes before the exercise he can start taking it, or some salbutamol he can take it that day. So salbutamol inhaler he can take that day, so that only during that episode that attack will wean. But if he's having frequent symptoms at least more than once a week, then he need to put on maintenance therapy. So the treatment for this patient, since the patient is polystraining, you need to put them on maintenance therapy of low dose ICS plus LABA. If he's infrequent, only on when needed he can put on SABA or LABA plus ICS. So this is a gold classification of COPD. Anything FEV1 by FEC is considered as obstructive disease. But after post-bronchodilator therapy, you can consider gold criteria. If FEV1 is more than 80%, that is suggestive of mild. 50 to 80 is moderate. 30 to 50 is severe. Less than 30 is very severe. So this is post-bronchodilator FEV1. So all this classification is post-bronchodilator. But for to diagnose, FEV1 by FEC should be less than 0.7 in the case of COPD. So this is MMRC grading, as we all mentioned. MMRC 0 is 2 strenuous exercise. 1 is uphill or hurrying up level. 2 is slower than the peers or has to stop when he's acting at one pace. 3 is after 100 meters he has to stop. 4 is too breathless to walk. So most of the patients that comes to our OPD are anywhere between 1 to 2. So, and CAT scoring is based on the symptomatology of the patient. He needs to score how much is having symptomatology, how much is affecting by the symptoms. So based on the cough, sputum will be taken into the account. Any chest tightness is there. Is having any breathlessness on walking uphill is there. Is there any fatigability? Is there a limitation of daily activities is there? How is his sleep? So all this needs to be taken. This needs to be scored by the patient. So after taking MMRC and CAT scoring, we need to differentiate into the gold assessment. So if MMRC is 0 to 1 and CAT scoring is less than, like he's not having severe symptomatology or shortness of breath is not very severe, he can be graded as A. So if the patient is having severe MMRC more than 2 and CAT score than more than 10, that is B. So on exacerbations also, like any 0 to 1 moderate is considered as A to B. If having patient is having anything more than 2 moderate exacerbation or at least one hospitalization, that is directly categorized E. So the treatment of this are variable. In A, you only advise bronchodilator therapy. In B, you can consider adding LABA plus LAMA. In E, you should definitely add LABA plus LAMA, and you should consider adding other drug also based on the symptomatology and what are the other clinical parameters you need to add. So in A, what do you add? I'll discuss in the later slide. So in A you added a bronchodilator therapy, either LABA or LAMA. So if the patient is having exacerbation, I prefer LAMA or LABA. So in B you can consider LABA plus LAMA. That is LAMA is tiotropium or glycopyrronic, LABA is formoterol. So you can add you can add them both. In group E you should definitely add LABA plus LAMA. So when do we add inhalation corticosteroids in COPD is one more call that I'll tell you. I'll discuss in the later slide. But this is one thing you need to add. So less symptomatology and less shortness of breath, no exacerbations, sir. You need only bronchodilator. If there is significant shortness of breath and some cat symptomatology, sir, you need to add both. If they are having exacerbation, you need to consider other therapies also. So this is when after LABA plus LAMA, you need to take into account the eosinophil count. So and the patient is having exacerbations, no eosinophil count is less than 300, you need to consider LABA plus LAMA. After adding LABA plus LAMA also, if blood eosinophil count is more than 100, you can consider adding inhalation corticosteroids. Or if you need to, if eosinophil count is more than 100, you can directly add inhalation corticosteroids. But if combination is there, of already in combination, if symptom is having severe exacerbation after combination also, if eosinophil count is more than 100, you can add inhalation corticosteroids. So that is the indication. Increase in eosinophil count is one indication for starting the inhalation corticosteroid. After this also, if the patient is having symptomatology, roflumilast is one drug, that is PDE4 inhibitor, that can be used as a FE1 less than 50%, and chronic bronchitis is one indication where you can ask roflumilast. So the patient is smoker, you can add azithromycin to prevent the exacerbation. So azithromycin can be used to prevent the exacerbation, especially in the smokers. So these are the next drugs you can add. That is one roflumilast, FE1 less than 50%, and chronic bronchitis, and azithromycin is the next drug in the smokers. So this is the indication. So initially, if LABA or LAMA eosinophil count is less than 300, you add LABA plus LAMA. Then also, if it's not 100, more than 100, you add LABA plus LAMA plus ICS. If less than 100, don't add steroids. So if LABA or LAMA is there, if blood eosinophil count is more than 300, you can directly add LABA plus LAMA plus ICS. So this is one. Always combination of three. Don't add LABA plus ICS. Both LABA plus LAMA plus ICS. So this more than 300. So this is the indication. So vaccination. This is one of the most important thing we ignore in the case of COPD patient. One thing, you need to adequately supplement, then vitamin D deficiencies will be there. So any nutritional and vitamin D deficiency should be corrected, and the patient should be adequately vaccinated with influenza vaccine and pneumococcal vaccine, definitively. And more than 50 years, you need to put them on zoster vaccine also. And if the people are not vaccinated for any pertussis vaccine and diphtheria vaccine, they need to be put on TDAP vaccine also. So especially influenza vaccine, which is every year, and pneumococcal vaccine, and also you need to put them on zoster vaccine if more than 50 years, and also you need to put on TDAP vaccine if they are not previously vaccinated or it's long time since the vaccination. I'll discuss about vaccination in elderly in a separate topic, but these are the vaccines you need to take into consideration. Definitely vaccination should be done. So one day there are various therapy. After that COPD also, these are the medical management of COPD. So there are some interventions you need to put them, like you need to put them on long-term oxygen therapy. When do you put on NIV ventilation? When do you go for lung resection, lung volume reduction surgery? These are all, there are definitely indication. There are indication for COPD to put on long-term oxygen therapy. First we will start with LTOT. So any patient who is having saturation less than 88% or PaO2 less than 55, you need to put them on long-term oxygen therapy. Or if the patient is having saturation more than 88% also, if the patient is having right heart failure, or patient is having erythrocytosis, or patient is having pulmonary hypertension, all these conditions are indication to start them on a long-term oxygen therapy. So you start them on oxygen therapy and titrate the SpO2 to more than 80%, and you assess every 2 to 3 months, you assess the patient. So if the patient is improving, you can decrease the oxygen therapy and stop. If the patient is still recovering, you can continue the therapy. So indications are any saturation less than 88%. If saturations are more than 88% also, if the patient is having polycythemia or right heart failure symptoms or pulmonary hypertension, you need to start them on long-term oxygen therapy to maintain saturation more than 90%. You assess them every 2 to 3 months. If the patient is no longer recovering, you can stop. If the criteria is not fitting, you can stop. So these are the various LABA plus LAMA plus ICS. Smoking cessation is one more important thing. Pulmonary ventilation, long-term, non-invasive ventilation. Like how do you put them on, when do you put them on a non-invasive ventilation? So any PCO2 more than 53, you indicate for a non-invasive ventilation, you need to put them on BiPAP or CPAP. Mainly BiPAP we put them on, where inspiratory pressure and expiratory pressure you will put. So you read about what are the indication for NIV in like non-invasive BiPAP therapy in patient. that PCO2 more than 53 is an indication. And the same way as you put on long-term oxygen, assess them every 2 to 3 months. If the patient is requiring the NIV ventilation, you continue. If the patient is no longer, you can stop it. So, but if the patient is having persistently PCO2 more than 53, after stabilization also, you need to put them on NIV BiPAP and put them in inspirator and expirator pressure, and reassess them every 2 months. And based on the VBG, you can ABG, you can you can titrate or you can stop based on the if still require, if indications are still there, you can continue. Lung volume reduction is mainly indicated in the case of upper lobe emphysema. This is the indication. This is a NEET SS question. Upper lobe emphysema and low exercise capacity is an indication for lung volume reduction surgery. So upper lobe emphysema and low volume capacity. Lower lobe emphysema and high volume exercise capacity is not an indication. Upper lobe emphysema and low volume exercise capacity is an indication for lung volume reduction. This is an important question. Remember, this definitely will come. So these are the inhalation bronchodilator. Always preferable LABA or LABA plus, like long acting drugs are preferred, or SABA. You advise SABA plus SAMA initially during the admission, like if the acute exacerbation is there, in hospital admission is there. In them you prefer SABA and SAMA combination, that is duolin. Duolin contains both ipratropium plus salbutamol, that is given every 6 to 8 hourly, that is thrice a day or 4 times a day. So in hospital admission you can put LABA and LAMA, that is duolin. So but at discharge you prefer LABA and LAMA combination, that is formoterol, tiotropium and all. So that is the main concept. In hospital admission you advise SABA plus SAMA. You can advise LABA plus LAMA in hospital admission also, but when discharge prefer LABA and LAMA. So when to use inhalation corticosteroids in patients? So if the patient have history of like when the strongly indicated, these are all gold guidelines. History of hospital admission for exacerbation of COPD, after the patient is put on LABA plus LAMA and eosinophil count is more than 100, or LABA or LAMA is using, and if eosinophil count is more than 300, you can directly put LABA plus LAMA plus ICS also. And more than 2 exacerbations are there, and blood eosinophil count is more than 300, or concomitant asthma history, like any asthma history, allergen exposure, any diurnal variation is there, atopy history is there, you can put them in inhalational corticosteroids. So this is one more thing. This is very important, but you should not use if the repeated immunity, like because steroids itself can cause pneumonia because they're prone to infection. Like because of the steroid, whatever, again they are prone to cause infection. So if the patient has a repeated pneumonia, repeated hospital admission because of LRT, you should not put them on inhalational corticosteroids. And blood eosinophil count more than less than 100, you should not use. Any history of mycobacterial infection also, you should not use them on inhalation corticosteroid treatment. So these are the against main always, because most of the inpatients will have pneumonias, repeated pneumonias. In them you won't put them on inhalational corticosteroids. And also blood eosinophil count, one thing you need to put, and history of mycobacterial infection is one more contraindication. So how do you manage exacerbation? So in hospital exacerbation, you generally would use SABA plus SABA without or SAMA, that is duolin you can use. And also systemic corticosteroids are advised. So systemic corticosteroids can improve the lung function, oxidation, and shorten the recovery and hospitalization, and duration should not be more than 5 days. So this is one most important thing. If you are giving hydrocort, that can be 50 mg IV TID or 50 mg IV QID or 100 mg IV BD, whatever you are giving, preferably we give 50 mg IV TID or QID. So because hydrocort acts for around 4 to 6 hours or something, so you need to give them not more than 5 days. So in acute exacerbation of COPD, you can use systemic corticosteroid, that is prednisolone or IV hydrocort, but you need to give them less than 5 days. So antibiotics you give, and non-invasive ventilation if needed. So oral corticosteroids have been used for not more than 5 days. You can start them oral corticosteroid, like prednisone also can be given, but we prefer systemic IV hydrocort, but not more than 5 days is the advisable thing. But inhalational corticosteroids should not be continued in the treatment phase, like outpatient also, especially in the patient who are in recurring pneumonias and blood eosinophil count is not more than 100 and all, and TB patients also should not use. So this is the history of asthma. Especially symptoms occur variably over time and often worsen at night or waking, especially early mornings, and triggered by excessive laughter or allergens or cold air. These are all the triggers, and also often worsen with any infection is there, the symptoms might be there. So this is the classical history of asthma. Anything if you want more than 12% or more, you read all this definition of asthma. There is a big definition of asthma, read about it. So this is the symptoms: wheezing, shortness of breath, chest tightness, and cough. Dry cough is the most common thing. So these are the asthma history. This is how you treatment. So first step 1 to 2, we trified only when needed ICS plus in ICS low dose ICS formoterol and all. So this is mostly patient who are infrequent symptoms, like once in a month or twice in a month. You advise only when needed only treatment. But patient is having weekly once treatment, you go for low dose maintenance inhalation corticosteroid plus formoterol. So if the patient is still having symptom, you go for medium dose inhalation corticosteroid formoterol, that is more than twice a week or thrice a week. But anything more than once a week, anything once a week or more, you need to put them on maintenance therapy. Then you can add LAMA, that is tiotropium can be added. Um, you can add Montelukast can be added. You can add IG. There are biologicals also. Mepolizumab, many drugs are available. Omalizumab are there. There are many drugs that can be added. So we'll discuss about in the asthma chapter. This is main. This is a preferred therapy, preferred control therapy. There is also alternative therapy where you can give inhalation corticosteroids. Like there is one patient who is the patient who are used to SABAs especially. So this is not preferred therapy actually, but you can they can take when reliever like infrequency, they can take only ICS and SABA when needed, and some next second dose you can put low dose maintenance ICS only, and SABA when needed they can take. So like the patient who are used to like especially the salbutamol inhibitor, levosalbutamol, they are used to it already. So in them, so they only when the symptoms are there, you add low dose inhalation corticosteroid them and take SABA with them when needed. But when they're requiring the maintenance dose, like the patient is having frequent symptoms like once in a week or then, you go with follow the same format as this. You go for low dose inhalation corticosteroid plus LABA and continue the same regimen. Only when infrequent symptoms are there, you can ask them to SABA, take SABA, and along with that low dose inhalation corticosteroid. Like you can get the budesonide inhaler separately, and along with that you can take salbutamol inhibitor, that is levosalbutamol inhibitor will be there. So you can combine both and take. But preferred regimen is always that. Is it easier to take both combination of low dose inhalation corticosteroid plus formoterol. So this is again the indication. This is the preferred regimen as we mentioned. Anything more than a week, you need more than once a week, you need to put them on maintenance therapy. So these are the various combination, low dose inhalation. But most common thing is budesonide we use. Anything 200 to 400 is budesonide. It is low dose. 400 to 800 is a medium dose, and more than 100 micrograms. That is Foracort 100, 200 are all low dose. 100 is the 100 micrograms of budesonide. 200 is 200 micrograms of budesonide. 400 is medium dose. That is what we also get. Fluticasone. Fluticasone is also like a Seraflow inhaler is there. In that fluticasone will be available. Less than 200 micrograms is low dose. More than 200 to 500 is medium dose. More than 500 is low dose. Beclomethasone inhalers are also available. Beclo some inhalers are there. That is also same as fluticasone. Less than 250, 250 to 500, more than 500. But most commonly in Foracort we will find budesonide. Less than 400, anything budesonide less than 400 is low dose. 400, 800 is medium dose. In fluticasone, less than 250 is medium, 250, 500 is medium dose. This is more important. You need to understand what is low dose and medium dose. So this is always salbutamol is asthma inhaler. This is aspirin that acts for salbutamol acts for 6 to 8 hours. That is should be used every 3 times or 4 times in a day. Beclate is beclomethasone inhaler, that is 200 micrograms. That is this is low dose inhaler. So in patients who are requiring like the patient second line regimen where the patient is requiring only inhalation corticosteroid and they take aspirin together, they can use this also. That is beclomethasone isolated only steroid inhaler there that is used in asthma. This is formoterol fumarate plus budesonide inhaler, that is 100, 200, 400. 100, 200 are combination. This should be taken twice in a day. So this should be taken twice in a day. So that can be 100, 200, 400 based on 100, 200 are low dose, 400 is medium dose. So dual inhaler is a combination of ipratropium plus salbutamol. So this is used especially in the case of acute COPD cases. Mainly COPD case in hospital admission we use. So in these patients you need to use it 3 to 4 times in a day. So this is used mainly in the case of asthma patient especially, that is twice in a day. These both are also used mostly in the case of asthma patients. Aerocort, what is Aerocort you read? That is mostly containing what Aerocort is. You read about it. What does Aerocort inhaler contain? How do you use it? That is one question I want to ask. And Seraflow is one more inhaler that contains salmeterol with fluticasone. Fluticasone 250 micrograms is a low dose, and salmeterol can also be. This is also can be used as a asthma inhaler, but mostly we use Foracort. Seraflow can also be used. So tiotropium, as I mentioned, tiotropium 9 microgram, this can be used once in a day. So you can combine that formoterol inhaler plus Tiotova inhaler. Tiotova inhaler is LAMA, which acts in once, can be used once in a day, whereas formoterol can be used twice in a day. Otherwise, there are other inhalers which has combination of LABA and LAMA. So this is the combination where foraglin is present. Foraglin is lycopyridine plus formoterol. This can be used twice in a day. This contains both LABA and LAMA. This can be used in the COPD patient, especially in discharge. So you can combination of both. Foraglin is there. You can use both combination. So tiotropium plus formoterol. This is one more inhaler that contains both LABA and LAMA. So this can be used initially can be started once in a day because tiotropium acts for 24 hours and formoterol acts for 12 hours. Initially start done once per day. If required, you can make it twice a day also. This is a combination inhaler. So thank you. But this you need to understand this also. What is this inhaler? So this is a metered dose inhaler. So there are 3 types of inhaler. One is deep pressure inhaler, like dry powder inhaler. Then the second is metered dose inhaler. There is also called someone that can generate a spray like inhalers are also available. So this is they generate mist kind of thing. So but most commonly used dry powder inhalers are metered dose inhaler. So generally we prefer metered dose inhaler because it doesn't require much pressure to be generated. So generally dry powder inhalers like whatever rota capsules, rota inhalers are there, no, they're all dry powder inhalers where they put the capsules and inhale. So they require a lot of pressure. So it requires a lot of respiratory capacities to generate such pressure, and so that that powder won't get deposited in the upper oral tract. So that you need to go inside, no, you need to generate a lot of pressure. That's why you don't advise dry powder inhalers like rota capsules in the elderly people. For especially in all elderly people, you need to put an MDA inhaler only. Only if they have enough respiratory capacity, only you need to put a dry powder inhaler. So MDA and DP are two common things we use. So dry powder inhalers are generally requires a lot of respiratory capacity to generate to, so that all the dry powder which are in it needs to go into the lungs. So they need a lot of respiratory capacity. So mostly preferred in younger people, which are rota inhalers are there, rota caps are there. They're all dry powder where the powder is there. You put the capsule in rota inhaler and inhale. So in all elderly people, you need to put them on MDA because they don't have enough respiratory capacity to expect. MDA doesn't require much pressure. It is a metered dose inhaler. It can generally direct go and deposit in the lungs. So this is a metered dose inhaler, that is a dry powder inhaler. We generally nowadays all are preferring MDAs only most of the times. So this is a case of, this is asthma versus COPD. Thank you.